All right. Good morning, everybody. Welcome to Pediatric Grand Rounds. I have the pleasure of introducing Dr. Christina Tancre, who's a pediatric hospitalist and clinical professor of pediatrics. As Associate Vice Chair of Quality for the Department of Pediatrics, she enjoys educating and serving as a resource to faculty, trainees, and staff in creating better outcomes through quality improvement. In her work as Associate Chief Safety Officer at Seattle Children's, Dr. Tancre leads efforts to create and sustain a culture of safety, including the use of many of the tools and concepts that she'll be discussing today. Her current portfolio within the Center for Quality and Patient Safety includes projects to improve psychological safety, escalation systems, and the use of high reliability principles, including leveraging leadership behaviors such as leader rounding to embrace organizational learning from the experts at the front line. She speaks in various venues locally at Seattle Children's and at the University of Washington, including the University of Washington Certificate Program in Patient Safety and Quality, as well as nationally and internationally on safety systems. She also serves on the executive committee of the AAP Council on Quality Improvement and Patient Safety, and she co-leads the West Region for the National Pediatric Safety Collaborative Solutions for Patient Safety. So excited to have her here. Let's give a warm welcome to Dr. Tancre. Thank you.
Thank you. I was just saying, it's been probably 2 years since I gave grand rounds, and so it is really nice to see people physically here in the room, and thank you for having me today. So we are talking today about safety systems, and there are a lot of topics, but they do build on each other. Believe it or not, I took a lot of topics out of this, had to exercise some restraint. And you won't believe it as you see all the things I'm going to fly through. But the ones that remain are really the core concepts that I think we should all have some familiarity with. And I want to make sure that I am clear that they really all connect with one another and are not separate initiatives. These strategies, when used together, really make healthcare safer for the children we serve and, frankly, for each other as well. So this is how we're going to do it. We will start with what it means to set the tone for safety as we talk a little bit about culture. Culture alone is a whole separate talk and discipline, so it will really be just focusing on a couple pieces of culture. But when one has that foundation, then we can actually understand the actual work of those on the front lines. Once that is done, then we can design or redesign systems that actually work for people. We'll talk about human factors. Then we want to really be able to use those systems reliably and under complexity, because we are in a complex industry. So these are what the high reliability principles are, which we'll touch upon. And then finally, and then we want to be able to think about what does it look like when we try to use these concepts and paradigms in a perfect setting, and then what happens when our system is stressed and we are stressed, and do the systems that we design still work when we're stressed out? And finally, we ensure that we're using all the available tools while considering risks that need monitoring. So when all these come together, we have an intentionally designed safety system. Now, these concepts can be very theoretical, and so I really want to make sure that I am presenting them in a way that allows us to all really be thinking about what each and every single one of us can do ourselves every day to embrace these concepts and actually use them. So that's partially because when I say systems, I don't mean multi-state healthcare entities, right? Your Tuesday afternoon clinic with your colleague and your MA and your front desk staff, that's a system that needs a system, right? My resident ward team for a given week and all of the people and the things that that encompasses, that's a system. So for each of these topics, I will offer very specific, concrete suggestions for how you can actively embrace the principles and create more safety in your system. So here are the objectives. There are a lot of them. Emily and I were chatting about them. But I feel very strongly that I will not give you objectives that I don't think that you'll be able to meet. And so by the end of this, I know, just 5, it's a bit of a fire hose, you will be able to assess system factors that create safety in pediatric healthcare, differentiate between human error and system weakness, apply these tactics that I just talked about, analyze signals of risk and leverage design principles to make things better, and evaluate the use of intelligent tools to augment your expertise and support our safety systems. So we'll start with the why. Why are we even talking about this today? Have we even made improvements in patient safety? We all work really hard every day to make sure that the system is safe for our patients and for those that love them and for all of us. But pediatric care is really complex, and harm does continue despite good intentions by good people who come to work every day to do the right thing. We are evolving beyond blame and beyond checklists, and to be thinking about what are the ways that we are going to keep going on our safety journey. Unfortunately, there's still a lot of harm for patients and inequitably for certain populations. Back in 2012, a group at Cincinnati did this seminal study where they looked at 240 random inpatient charts retrospectively for the previous 12 months and looked for one or more of 50 or so predefined safety triggers using the global trigger tool. What they found was about 37 adverse events per 100 admissions, and they found that a quarter of all patients studied had at least one adverse event during their hospitalization. That was much bigger numbers than had been published prior to that in this particular setting. On the right, you'll see the information from a 2023 meta-analysis that looked at 32 studies, looking at 34,000 pediatric admissions, and they found an about 25% adverse event rate, so fairly similar. So despite the original call to action in 1999, I've never, ever given a safety talk to a large audience where I didn't show this original thinking around the fact that we really needed to look at patient safety as a top priority in society. We still have harm that still persists, and we've been trying to prevent it. Some part of the focus today, though, has really been looking at what has already occurred. That's really the classic model, right? Analyze something that happened, mitigate it, put fixes into place to try to prevent it. That model is now called Safety 1, and we'll talk about Safety 2, and it has improved care over the years. But have we reached the limits of how much more improvement we can get from the types of things that Safety 1 gives us? Because healthcare is more complex than ever, and as our journey in patient safety keeps going, the complexity of our patients and of our systems continues to increase as well. So every day you navigate workload and unclear processes and cognitive overload and what we call goal conflicts, or what seem like multiple competing priorities that kind of have to be navigated. Well, what actually is the priority? And they don't always align. We know we're at a critical time in the history of healthcare. We have staffing shortages, looming further staffing shortages, resource scarcity. So national groups like the Institute for Healthcare Improvement have really been working hard to think about frameworks and action plans and blueprints for how we're going to make things better. And those thoughts really encompass this idea of the human as a part of the system and how we all interact together, because that system continues to expand. This is the classic quality improvement, quality outcomes model by the founder, really, of quality improvement, Avidis Donabedian. It's called the Donabedian model. I say these words just about once a week on a regular basis. Oh, structure, process, outcome. This is an incredibly elegant model, and we don't quite capture the complexity of modern healthcare in models like this. So there are now models like the SEEPS model, the Systems Engineering Initiative for Patient Safety, that really attempts to try to better describe what it is that we all do on an everyday basis, so that if we're going to try to make improvements, we have a better understanding of what things look like. So too, this Swiss cheese model that most of you are familiar with, that was created by psychologist James Reason many years ago, it also continues to resonate. I still use this when I teach people concept of patient safety, but this one, again, doesn't quite capture the subtleties of what we are all working through every day. And so this in particular, I found this in a mining safety website with a big notice on it that said, use this wherever you want. They're very proud of it. And I love that this calls out goal conflicts and mixed messages and production pressures and all of the various things that every single one of us is working through as we try to think about how we navigate modern healthcare, modern safety. So we'll get back to goal conflicts in just a bit, but before we do, I want to talk about the concept of error. And let's pause and think about what we think when we see the words human error and what we feel, because it's not always the same.
It's not in quotes because I don't believe it exists. It does, but it's in quotes because the connotation that comes to mind for many people is still blame. If you don't think we blame people for making mistakes, I would ask you to pause and think about what words you said to yourself the last time you made a mistake and worried about it and thought it affected the patient. We talk to ourselves in different ways than we often talk to others. And we may not blame other people, and we say it's the system, but then what do we do when it's ourselves? So I do think we still blame people for making mistakes. Sidney Decker, a prolific safety expert, explains that we can't really look at error as the cause of a bad thing that happens in healthcare. We actually have to look at it as a symptom of the bad design that allowed that to happen. And it is a fundamental flip in the way that we think about that interaction between people and events that allows us to also think about how we then make things better. Now, experts have known this for a very long time. This is Dr. Paul Fitz. He's a psychologist and one of the very first human factors experts. And in 1947, so 78 years ago, he and colleague Richard Jones published this study, and they put pilot error in quotes in this study where they looked at factors contributing to pilot error experiences. Here is what the paper said. It should be possible to eliminate a large proportion of so-called pilot error accidents by designing equipment in accordance with human requirement. So this is our goal, right? Designing not just the equipment, but the environment and the culture and the system in accordance with human requirement. And that's because in this new view, known all the way back in 1947, humans are the solution to problems, not the cause of problems. So here's a quote from Decker. The interesting story is how in the resource-constrained and goal-conflicted world in which your people work, in which we all work, their activities mostly contribute to success rather than failure. People have to create safety, despite a system that places other, sometimes contradictory demands and expectations on them. So now we've swung as an industry from the old-fashioned blame and shame over to, well, the system is what we need to look at because we need to use the system to keep the human error from reaching the patient, and then pushed even further beyond that to, did the system actually shape the person in such a way that it actually led to the human error? It doesn't always apply, and I'll talk to you about a framework called Just Culture in just a couple of slides that really looks at the source of behavior change that people, behaviors that people choose to do and whether they are human error or other. But we really do want to be focusing on this interaction between humans and systems. And in order to do that, people really have to feel safe to interface and engage with the system. So we'll talk about culture and how we can make people feel safe. Culture is the ensemble of beliefs, assumptions, values, norms, actions, and language patterns shared by members of an organization. That is a non-healthcare definition. That is my Britannica definition, but it works really well for me, I think. And safety culture in particular refers to shared values prioritizing safety. It's the foundation of all these other things we're talking about. There is a lot that makes up culture. As I said, we'll not have time to talk about all of it, but I want to focus on these two concepts of psychological safety and just culture. And I have that in quotes because I'm going to define what we mean by just. Safety culture hinges on these things. And psychological safety was defined by a business psychologist named Amy Edmondson, who has published a ton of books. She's out at Harvard about teaming and leading and how we perform as humans. And she defines psychological safety as safety for interpersonal risk-taking to speak up with ideas, questions, or concerns. So I gave a whole other grand round specifically about psychological safety, and in one slide I will reference what I spent about an hour talking about then. But this is a very near and dear topic for me, and so please find me if you want to chat about it further. Just culture as a framework really sets up this concept of psychological safety. So again, just culture, as in correct, fair, right? I often actually call it fair and just culture. There are some groups that actually call it that specifically because that immediately sets up people to know that we're not talking about just in the context of only, like only culture. It's just fair and just culture. And it is an intentional framework for consistent, fair, and accountable response to events framed around behavior over outcome. This framework requires us to really look at human behavior and ask the questions. What made sense to this person at this time? How did the system contribute? What risks and incentives were there? Did they know the risk? Did they understand it? And if so, did they choose it regardless? By asking those questions and then actually taking it through a very clear algorithm, the paradigm really classifies behavior into 3 categories. And it doesn't have us look at the outcome of the behavior. It doesn't have us just look at harm. It has us look at the actions. Then it makes sure that the response to the behaviors is appropriate. So one does not coach reckless behavior, nor does one punish human error. By not allowing inappropriate behavior on this end of the spectrum to continue, but by not penalizing errors on the other end, we set up a fair response, a clear and consistent response for all of us. And what that does is it contributes to trust and psychological safety. It creates safety outcomes. Because a culture that is unfair and punitive and inconsistent leads to people in it who think that they will get in trouble for reasonably making a mistake that they were set up by the system to make. They will never report this, and that leads to poor learning and poor ability to make change, and that leads to more bad outcomes, and the cycle continues. But if staff think that the response is fair and report, the system can then look at the error or the context around what happened and make a fix. We see signals, we hear about them, and then we can act on them. Done well, this framework leads to increased trust, increased transparency, reporting, increased conversation, ultimately innovation, and better outcomes that we're all looking for. If we want to do safety and innovation at scale, we need these foundational cultural pieces. And when we don't have just culture, here's an example. A dosing discrepancy is caught prior to administration, but it doesn't feel safe to report, so no one says anything and the system is unchanged. And the next time, the same discrepancy happens. It's not caught by someone else, a patient is harmed, and we start to say, well, who made a mistake? And that gets back to everybody else, and the loop continues, and we don't learn, and the people who do the work know what all the risks are, and everybody else does not truly understand it. So we want to make sure that we are, that we are thinking through the consequences of our response to people's behavior in terms of our safety culture. So we can't talk about culture without discussing wellness. And this is not work that I own, and I'm very lucky that Kim Stone is in the audience and Clara might be online, and the folks who really own the bigger picture concept are here, and I thank them for their thoughts. As I really said, I have to be able to touch on this so folks can see how all of these different puzzle pieces fit together. There are links to outcomes, and burnout is a consequence of lack of an inappropriate, or lack of a just and fair culture and systems that are really set up to allow people to succeed. It takes constant work to kind of create and keep these systems going. And I am very happy that those of us here at Seattle Children's work in an environment where this is really being prioritized right now as an institutional strategic priority, and thinking about how wellness really makes a difference for all of us and for our patients. I mentioned the idea of blame and how we think that we are in a blameless culture, but even when we look at ourselves, how do we treat ourselves when something has happened? And what kind of judgment do we then place upon ourselves, and how does that lead to burnout? Burnout is a syndrome conceptualized as resulting from chronic workplace stress that has not been successfully managed. In putting this talk together, I learned that burnout is in the ICD-11. I had no idea. It's considered an outcome in itself that leads to further outcomes. And it has these 3 different dimensions: feelings of depletion or exhaustion, increased mental distancing, and reduced efficacy. The burden is massive. This classic study by Shanafelt et al. Looked at physicians using the Maslach burnout inventory and found that up to half, on average, of physicians reported at least one symptom. You can see rates across specialties here. We also know that structural inequities play a significant role in burnout. Clinicians from marginalized or underrepresented groups are disproportionately affected. This is clearly a system issue. And it's a vicious cycle. So system issues that can lead to burnout, lead to workforce instability, which then leads back to more system instability, and we have to interrupt this loop. This instability also clearly affects patients, as the evidence for burnout being linked to patient outcomes, quality and safety outcomes, is quite clear. This Salyer's meta-analysis, the one on the bottom left, in particular, looked in total during the meta-analysis at 200,000 healthcare providers and found statistically significant negative relationships between burnout and quality and safety. The idea, too, that, and thank you, Kim, for sharing this idea, which I hadn't specifically incorporated before, that physicians are leaders regardless of where you are. And as members of teams, any burnout that any of us experiences, whether we mean to or not, can really trickle into the relationships, the systems formed within there, and then really negatively affect the patient-family experience in addition to these outcomes that I'm mentioning. So clearly addressing this as a safety strategy, and improvements in this area have the same themes as any of the other areas that I've talked about: better systems, better outcomes. We have to intentionally design for safety and reliability that takes worker well-being into account. And by designing for things like psychological safety, which we talked about, and intuitive processes and workflows, and working through the expected and the unexpected, using intelligent tools, which we'll talk more about, we get to these better outcomes that we're hoping for. So for this issue of culture, really, we can get the results we want by interrupting these negative loops that I just talked about via intentional design. And even though culture is the foundation, we build that too, right? We make the culture that we want to allow all of the next steps to happen. And there are active steps that each and every one of us can take to build the culture we want in all of our various systems as well. So at the system level and for our own teams, if you want to build psychological safety, there are tools that you can use. There are ways to actually explicitly make a part of the norms of your groups what it is like to question and to challenge and to work together. I had to take a whole section on teaming out, but there are entire massive curricula like team steps that really look at what some of these tools look like. If we want a fair and just culture, we need to have consistent use of a formalized framework. We need robust event reporting. Now, Seattle Children's has rolled out Just Culture, and so for anybody who wants to know more about it, you can actually look on Child for the Just Culture page, where there's some great links to the why, some quick videos, the algorithms themselves. So this is a really great time for us to be talking about this. So here is your what can you do slide for culture, right? I promise that you will have actual things you can do today, next week, every day for each of these sections. So pause before assuming what we really mean by human error. So whether that is in M&Ms, if you go to M&Ms, whether that is just in discussions in wherever your various workplaces are, pause and think, what made this make sense in the moment? And shift your thinking a little bit. Ask for help, give grace. And really engage in the improvement work because, like I said, these are topics that we've all been talking about for years. And right now, actively, like this month, we have big initiatives and big work happening to really look through these. And we need your opinions, and we want you involved. Okay, so we're going to shift from the cultural foundation to this idea of if everybody is not stretched so thin culturally, we're capable of really moving towards the next step in our safety journey, which is learning from everyday successes. So we're going to do a case. An 8-year-old girl presents to the ED with fever and cough. She's been tolerating her G-tube feeds, but has been having coughing fits and is not sleeping well. She's hypoxemic and found to have flu A, and she is admitted to the acute care unit for supportive care. Within the first 2 hours of admission, her vitals do not worsen, and she does not experience a change in her assessments to meet any sort of triggers for escalation. The nurse notes that her work of breathing is difficult to assess. The child's mother says, "I hope she doesn't have to go to the ICU again. She just doesn't quite look right." The nurse calls the resident, who comes to evaluate the child. All agree the patient's exam is unchanged. But mother made that comment. They ask the RT to come and evaluate. They place a PIV. One wasn't able to be placed earlier. They stop feeds. They increase her vital sign check frequency. The intern notifies the senior resident, the nurse notifies the charge nurse. They all notify the risk nurse of mother's concern, which doesn't have a lot of objective evidence behind it. She just has concern. 3 hours later, the patient acutely decompensates, is transferred to the ICU for non-invasive ventilation and increased monitoring, and the patient recovers without difficulty and is discharged home 5 days later. One time I presented a case, I made this case up, but one time I presented a case like this at resident M&M. It was probably 4 or 5 years ago, so probably way before y'all were there. And everybody just kind of looked at me like, why are we talking about this? What's happening? So why am I presenting this case? Did something go poorly in this case? Is there anything to learn? Why did this patient do okay? I have had people tell me about incredibly complicated cases where dozens of people came together, and I said, I really want to study that. I really want to learn from that. What happened? Tell me about it. And the answers I've gotten are, I'm just doing my job. I just had good people there that night. It was really good teamwork. And maybe part of that is true, and there's so much more underneath that, right? How did the people who did a really good job know what to do? Who taught them? How do we replicate that? Teamwork is teachable. There's forward thinking. There's all kinds of principles in here. This is just really rich. So how often do we really pause to study cases like this? And what might we gain if we did it on a more regular basis? Because the majority of our cases are successes, but we don't study them. So for success stories like this, that classic safety one model I was talking about, it doesn't suffice, right? Those kinds of cases really disappear in that world. So in this case, there were no errors, no policies to consider, no failed escalation triggers. Safety emerged from what we call work as done in the real world as opposed to work as imagined. People had gut feelings. Those of you who've ever kind of done something based on a gut feeling, and then afterwards gone, oh, I don't know why did that work? That gut feeling is actually cognitive. It's pattern recognition, that you're not actually, able to pinpoint exactly what the pattern is that you're seeing. That gut feeling comes from somewhere. There was respect for expertise all around, right? The mother's expertise and the nurse's expertise. There were lots of high reliability behaviors and culture. There was centering on the patient. Stories like this are not surprising in pediatrics. We see this all the time. We use parental concerns as part of the story. This isn't luck. This isn't heroism. It's adaptive behavior in the system. And this can be taught and replicated if it's visible and supported and formally reinforced. Now, we are lucky that we do have models here where we look at cases like this. And we all have the opportunity to really be much more formal and robust about it. The classic safety one model, the traditional model of patient safety, focuses on reducing harm by preventing errors, where this safety two model looks at increasing system resilience and capacity. Instead of asking what went wrong, we say, how does this usually go right? We don't assume we create safety just by preventing recurrence of what we used to call deviations from protocol, but we create safety, as I mentioned earlier in the talk. So let me be very clear, there is no safety work without safety one. It is very necessary, and it is insufficient. If just a small minority of our cases are accidents and disasters and serious safety events, and the majority are not, it really behooves us to ensure that we don't just focus on the processes and learnings for these pieces in the red, but looking at the everyday. So that's because the founder of this model, Eric Holnagel, was a Brazilian engineer, really posited this idea that harm events and non-harm events don't happen like this, where there's two different processes that are occurring, but rather there's really no difference, and that there's just the work that everybody does every day, and there's variability within that, and sometimes it goes well, and sometimes it doesn't go well, and we have to accept that that's the system and learn from the work as a whole. He really suggests that we redefine what safety really is, that it's not just the idea of no bad things, it's the idea of as many good things as possible. That we don't just look at things in reaction, but that we are proactive. This, for me, is the key principle that I needed to really be able to kind of latch onto this. Humans are not a problem to be fixed. Humans are actually the solutions to the problems. And that really, we as we look at investigations, we really want to be thinking about how we replicate. So again, let me be very clear that significant harm events really do have to have a deep dive. We want to have a specific, deep understanding of when something does cause serious harm. But we can't only look at the acute, and we can't only look at the temporally kind of behind us ideas. We really have to look at both the proactive, the reactive, the acute, and the chronic to really get a sense of what the whole of the picture is. Like I said, the most fundamental shift for me, people are actually our best asset. And when people are allowed to flourish and do their best work, they not only adapt, but that's where we innovate, and that's where we are able to create incredible outcomes together. There's a lot of tools for looking at safety too. We're not going to go through all these, especially the very, very complicated models down below. But I do want to talk, for example, about debriefs and huddles. You're doing them every day, right? Many of you. So how do we think about these ideas of what went well and how can we do that again? So not just naming the things that went well, but actually actively finding a way to replicate them and sharing those learnings so that not just the people who are in that huddle learn from it, but everyone can learn from it. And it can't just be a quick thing that you start with or an afterthought, okay, what went well? And then really focus on all the things that need to be looked at that didn't go well. We have to really have that appropriate balance. We are very lucky to have amazing sim expertise here led by Jen Reed. And in the learning environment of simulation, really people can also adapt to find new ways of doing things. And there's so much to learn and replicate there. And then the traditional Safety 1 tools, they can be used in this way as well. So things like root cause analysis and FMEA, which is failure modes and effect analysis. Root cause analysis, look at an event that already happened, do a deep dive. Failure modes and effect analysis, look at a process, or you can look at anything, a building, a new piece of equipment. Forward thinking, think of all the ways it can fail. But we can really tweak that, and we can use these principles within that. So here at Seattle Children's, our teams really look regularly during our root cause analyses as at the idea of work as done versus work as imagined. For years now, we haven't just looked at, okay, what's supposed to happen and what happened this time, but what's supposed to happen, what usually happens, and what happened this time, because that might be three totally different things. And we also really like to embrace that concept of FMEA and that proactive thinking, where despite the name having the word failure in it, you can also think about all the ways that something can go right. And I always love sharing this. Nick Mayo at Harborview has this love bug, where those of you who are familiar with fish bones, Ishikawa diagrams, cause and effect, this left-hand side, a tool that we use when we traditionally use when we look at things like root cause analyses. But if you actually think of all the things that went right and give it equal footing, at least equal footing, there's a lot more learning there too. Finally, I know this is a busy slide, but Solutions for Patient Safety, the National Pediatric Patient Safety Collaborative, is really focusing right now on the concept of proactive safety, which is their amalgamation of Safety 2 and a number of other different, really similar concepts. And there are people in camps. And so they're saying modern safety, proactive safety, how do we really kind of change the way we do things? And we're very lucky that we have expertise here, and that Laura Wood is the Associate Clinical Director of SPS and also is a consultant here. And so we're excited to try some more of these tools. So these Safety 2 tools really focus quite a bit on how humans and the system interact. You've heard me say that over and over and over again so far. Since our work is complicated and doesn't always really conform to the exact same standard, we really do have to address how well the system is designed to support how we work. And that's human factors in healthcare. So the goal being an optimal interface between the systems and the humans. And as we use new technologies, for example, we really have to study how we use the technology, and then how the technology shapes us, maybe changes our behavior, changes the way that we function in our everyday work as well. Think of the EHR, for example, and think of how you're not just using the EHR. The way that the EHR then works changes some of your daily processes. Think of how we interact with our phones and with all of the different technology that we have. Human factors really has to take all of that into account. And this is the main goal of the work. Make the work mesh with the human. Don't force the human to work with the machine, the system. There are lots of examples of this and how we make it really easy to do the right thing. So efforts to reduce alarm fatigue and alert fatigue. Things like best practice advisories that you get in whatever order entry system you use where you work, where those are placed and exactly how they pop up, that takes human factors into account, right? Look-alike, sound-alike medications. There are stories in the news, lots of things that people know about dangers from look-alike, sound-alike medications. There is a lot of human factors at play there in work to try to keep harm from happening related to that. Those of you who remember the concept of 5S from when we talked a lot more about lean principles, the way we lay things out, when you go into the supply rooms and you see everything labeled, there are human factors at play there, right? Color coding. I have had patients who have needed color coding for their medications so they know exactly which medications to take when. Perfect example of how we think about human factors. Sign out tools, being in the order of the way that you verbally do sign out. So I'm seeing the residents nod right back when we first rolled out iPass, and then we rolled out Epic, and we had to think about how those all meshed together. That looked at human factors, right? How we include different languages when we think about patient handouts and discharge instructions. Again, same thing. So many of these examples were put into place by folks who do this type of work every day. But as you go about your day today and think about what you heard today and thought about today, what would make things easier for you in your everyday work? So here's your slide again on what you can do. Safety 2 and human factors. In your debriefs, in your M&Ms, in your end of the day, personal look back, identify one thing that went well and replicate the best practices. Residents who've worked with me, you see me do this at the end of every day. Let's do our huddle. What went well? No limits to the number of things that went well. Only one thing you can tell me that you want to do differently tomorrow, but we're going to replicate the things that went well. Try a low fidelity simulation. I came in here and stood at this podium about 18 hours ago, and I stood here and I said, okay, it's been 2 years since I've done grand rounds in here. Do I have everything I need? I did a low fidelity simulation. And identify one workaround that you do and think about why it's a workaround. What is that telling you about the thing you are trying to do? And does it need to be fixed? Or actually is your workaround the way everybody should be doing it? And escalate that. Okay, so now what? So we understand, we talked about the work done in real life and what's happening out there. We talked about the interactions between ourselves and the systems. So now we're going to think about what does it actually take to run a safe system? How do we keep things going reliably? And then after that, we're going to look at pressure test it. What happens when we're stressed out as a system? So these are the principles of high reliability as originally described in this book, Managing the Unexpected, by 2 organizational psychologists. This is a really easy read. I know a lot of the stuff I talk about, I'm kind of nerdy. This book is, it's got examples, it's just a quick read. I recommend it to everybody. And what it does is it explains the concepts of these 5 concepts around reliability. How do high complexity industries, so healthcare is a high complexity industry. A lot of this work came out of nuclear engineering and civil aviation and the military. How do we stay out of trouble in the first place using these 3 principles? And then once we're in trouble, once something happens, how do we get out of trouble using these 2 principles? Now, again, I give like a 2.5-hour workshop on just this slide. So it feels a little bit like I'm blazing past this, but what I want to do is just really be able to share this wording with you so that the next time maybe you're somewhere and somebody says, are you aware of the concept of high reliability? You say, oh, yes, I am. I know all about high reliability. The 5 principles are mostly intuitive. Sensitivity to operations means paying attention to what's actually happening on the front line. Preoccupation with failure, y'all do this all the time. treating inconsequential errors as a danger signal. How do you think ahead to what the worst thing that could happen could be? This is a slightly harder concept. It was originally called reluctance to simplify. So here we have added the word interpretations to it because people have said, well, don't we want to simplify things and make them cleaner and easier? And this is more about not accepting the easy answer for things, understanding the entirety of the situation, asking for different people's opinions. Resilience is a concept we'll talk a little bit more about in the next section, bouncing back from adverse circumstances, and then deference to expertise. Who are the real experts in a situation? It's not the person at the top of the hierarchy. And how do we actually give that person decision-making authority when we need it? So that's high reliability in like 2 slides. It feels to me. But I do want to call out that there is a way to use these principles every single day. So a number of years ago, Rachel Vandemark, who used to work here as a patient safety consultant and a number of other things, she and I got together and we crafted scripting questions for people to use in problem solving. We actually first rolled this out during the COVID EOC to say, what are the ways that we can have people embrace the principles, but in a really actionable way? And so we made badge cards. And so if anybody, you can see it on the slide, and the slides are online, but if you want a badge card, let me know. You can use these questions in just your everyday problem solving, right? In rounds and when you're trying to work on projects. What is working or not working in this process? Are we missing anyone who actually does the work? What are the risks? What alternate perspectives do you have? Who hasn't weighed in yet? Will this withstand a pressure test? Do we have all the information we need to make a decision? I know people who just kind of, look and then just think about it and think through it rather than maybe even saying it every single one out loud, right? You pick 1 or 2, but this is a really concrete thing that I really encourage everybody to think about. And you saw the word resilience. So it means different things in different spaces, but essentially in both the HRO and resilience engineering world, which is what I'm going to talk about just for 1 or 2 slides here. It means that the system has the ability to keep going even when things are difficult. And in order to do that, we need capacity. That's the main word affiliated with resilience engineering. So intentionally designing for the ability to adjust before, during, and after disturbances. So it's about building this capacity for adaptation to continue during difficult times and recover from difficult times. Now, these can be major disasters, right? Or it can just be lack of availability of an interpreter phone line when you need to talk to a patient, right? All of these are stress tests on a system. So do the systems that we've designed withstand the test of something unexpected happening? And if they don't, how do we make them able to withstand that test? We know people get sick and can't come to work. And we know when viral surge season happens, right? We put redundancies in place, and we staff up, and we have backup staff on call, and we cross-train. Let's think about other issues. We create downtime procedures, right? We have flashlights and backup generators, and we keep an extra trach at the bedside. We have all these redundancies that we put into place because we don't assume that everything will be perfect all the time. This is a way that we really actively, ahead of time, say, do we have what we need? So for you, what can you do for these concepts? You can try one of those scripting questions, and you can pressure test your process. So think about your backup plans. Think about something that you do every day and say, okay, now if I threw a couple of wrenches in my perfect day, what would this look like? And is there anything I need to do to try to give myself some backup space? And finally, clearly this is not a talk about AI and predictive analytics because it is 8:46 and I am getting to it here, and I am certainly not an expert, and we have experts in the room and online, but we do have to talk about how we incorporate intelligent tools into these systems that we're talking about. There is a new-ish, I think it's fair to say new, primer on AI on child for anybody who's interested. I started when I was gifted a book by Paul Sherrick to read on AI in healthcare. And I have to say, before I started doing my own reading, I don't really know what's going on. And now I use systems every single day for lots of different things. And so I am a a case for illustrating that anybody can really learn these processes and learn to use them well. You may not think you use AI in your everyday work if you're not somebody who has actively embraced it, but you are. It's already influencing all of us, right? It's shaping care delivery and clinical decisions and processes and workflows and risk identification and decision support. So we all agree there's no question about whether AI will continue to play a large role in healthcare. It's really whether we're prepared to use it safely, equitably, efficiently, within all of the pillars of quality. It's not hype, right? It's inevitable, and it needs intention. So there are many uses for AI in healthcare, obviously, including supporting equitable outcomes and improving burnout via efficiency. But I'm going to focus today on use by the individual clinician and on use for safety outcomes. Within the individual clinician realm, right, many of you may already be using AI tools in your patient care. Your patients may be using it quite a bit as well. I have a particular interest in diagnostic excellence, and so in addition to using it as a cognitive aid, when I gave a grand rounds a number of years ago on diagnostic excellence, this was not a topic in there. So what does that say? I mean, it kind of boggles my mind right now that this was not a topic during an entire hour grand rounds on diagnostic excellence. But remember that, AI tools don't have the fatigue that we have, and they don't forget, and they are a partner in the work that we do. Also remember that it is never a replacement to clinician sound judgment, and I think those of us that use it regularly have lots of examples of times when we got information and we were like, that's not right. That is not right, and I'm glad I know what I'm doing, and I validated it. Now, at the system level, it can help us in a few ways, but the common denominator of its strength is pattern recognition and signal amplification. So at the patient-specific level, it can help pick up signs of some of the most dangerous and consequential diagnoses like sepsis. We're so lucky to have people like Joan Roberts and Lori Ruttman who do work around this. Joan has been an international authority on predictive analytics and deterioration for years. And so we have a lot that we have done and a lot more that we can do in this space. And then the quality safety process realm, really we can use it to help us detect adverse events more quickly, more robustly, to help us classify and categorize events. It can help us look at system signals and pick up things that we can't pick up on our own with our own eyes, look at thematic risks, recognizing patterns maybe across various units. Within the patient safety department, Erin Alberta is leading work to validate some tools that can look at our event reporting, for example, and help to classify and categorize events and then find some of these patterns. This fairly well-known scoping review by Bates et al. Looks at two of the things I already mentioned: high priority AI targets, decompensation, and diagnostic errors. I can't not mention adverse drug events as another really high priority area for how we can actually make good outcomes improvements with the use of these such tools. So there are risks. There are lots of future directions. There are lots of folks who spend a ton of time thinking about this. I just want to mention, I already mentioned the need for human validation as I talk about new risks and new tools. We also worry about data set drift, the information that we're feeding into our AI systems. We worry about performance drift, what comes out of our AI systems based on what we have taught it. We worry about bias. So AI tools can help us remove bias in some ways, but they can also introduce bias into a system. They can also, just like I talked about, the way that humans and systems shape each other, they can shape us to then have bias, including the concept like automation bias of I'm just going to ask my AI tool this and then I'll just do what it tells me to do, and that's a scary place to be. We do need to look at the concept of pediatric specific data and tools constantly, right? A lot of AI models have been trained on adult patients, and so we cannot just trust that they are appropriate for pediatric patients. Like any other quality initiative, we need metrics that we follow. What are the outcomes we're seeing? What are the different processes? What are some of the things that we need to keep in mind that might be changed in a negative way? So what are the balancing metrics? And then governance and oversight and accountability. So here at Seattle Children's, we have what's called an AIRB, right? An institutional review board for AI use. And we're lucky that this is a very thoughtful conversation around what are the ethics around AI use and how do we make sure that it's being done appropriately. And then finally, from a quality and safety perspective, we really do need to integrate anything we do with the processes that already exist, make sure that there are no silos of work happening. If anybody wants to hear how I used AI for this talk, come and find me. I didn't say write me a talk, right? But there's very, very specific things I used it for. And I find the variability across all of our comfort. This is just something I'm just passionate about talking about. So come find me. So I didn't even have to write my own slide. I did on this. And then I actually found, gosh, IHI, I love you. Not only do they have this patient safety and artificial intelligence expert panel report that recently came out, but they have a whole section on, for those of you who are clinicians, they have all these various considerations for key groups, like 4 or 5 different key groups and one for patients. And so this is the one for clinicians. This is what they want you to do, right? Reinvest your saved time into improving patient care, advocate for improvements, recognize the discrepancies that might need to be reconciled, work to learn new skills and retain old skills. I love this one. And consider AI tools as an aid, not a replacement. I love the word augmentation, right? Okay, so as I conclude, I want to just end by talking again about intentional design. This is the model that I use. I put a lot of thought into this, and it's very academic and it's very theoretical. But it again illustrates the idea of all of these pieces fitting together, and that we have to have our cultural foundation. And then on top of that, we have our enablers, like safety 2 concepts and human factors design. And then we have our operational models for success. You have actual questions you can use and huddles you can do. And then we have our tools on top of that. And we put all these together, feeds the foundation again, and it allows for more safe care. Complexity is okay if it's intentionally built that way, right? If it works, that's okay. So that's really where the intentionality word comes into play. So my call to action, there were lots of them throughout the talk. I thought about pulling them all into one slide, but I thought that would be a lot because there were so many. So I just wanted to reframe it as, what thinking can each of us reframe a little bit? And what processes can we redesign? We have agency to redesign on our own in our everyday work. So lots of acknowledgments. Thanks to the folks who took a look at my slides, right? I mean, I showed Clara Lynn my AI slides and said, well, am I saying something wrong? And so it's a team sport. We've been saying that phrase a lot this week. All this work is a team sport. So
hi, thank you, Dr. Tancre,
thank
for
you,
this.
Dr. Walker.
Probably, I would say this, if this is not the most important grand rounds of the year, it is right up there. This is critical, and I'm so glad that you're doing this. And I also want to thank you for the work you've done here and nationally. We've gone to a whole different level of safety and quality in the last probably 7 years. And I've been here 16 or so. And so I have a question for you, because when people sit and they listen to quality, safety, most people, I would imagine, say, I do a good job. And things are good and cool. Just cut your fine, I'll do the little online thing. But what we really, how do you get somebody to go from that to jump them into, my God, I need to be exceptional at this. Good is not good enough. And I want to help drive to, zero, as close as we can, get to zero system failure, right? The preventable failure.
Yeah.
So how do we motivate the people who are listening, say, oh yeah, I do this well, to get, no, good is not good enough. We need exceptional.
Yeah.
We need it every day. We need a reliable system to bring that on. So I'm curious, you've delved in and clearly are just totally immersed and excited with this field. How do we get more people to realize that good is not good enough and that we really need to jump?
I have 3 thoughts. So I had two, and then I looked at Kim, and I was like, oh, I have a third thought. So one, the work on wellness. If people are burned out, they by definition have that disconnect. So that's a thought. But the original two thoughts I had were, one, around the idea of what are the ways that people, in terms of change management, what do they react to? And so some people react to data. So for those people, data. But a lot of people react to stories. And they react to stories that really resonate for them in terms of their own patient care or their family members. And so how do we find those stories and share them in a much more robust and meaningful way? And there's a concept called provider calibration in diagnostic excellence. And so, we talk a lot about accountability. So you may think that you're doing a really good job, but if you don't have the data to prove that you yourself are doing a really good job at whatever domains we've decided are important, then your brain is not calibrated to actually understand where your opportunities are. And so those feedback loops are really an opportunity as well. Thank you.
Dr. Tancre, this is my first pediatric grand rounds at Seattle Children's, and I'm super excited.
And I got to stand here and
the
talk about
topic.
AI and say, hey, Chris, how's it going?
And high reliability and just culture, and I really appreciate it. And my question for you is, as we talk about safety one and safety two, the safety one tools like FMEAs and RCAs are incredibly resource intensive.
Yes.
How do you suggest you balance and allocate your investments across both of those, given that there's different yield on each?
Yeah. As many of you know, we actively worked on this a number of years ago when we realized that we were doing 25 enterprise-wide root cause analyses per year and not actually seeing the kinds of changes we wanted to see from that. And so it was counterintuitive to step back at that point and say, let's shoot for 7 or 8 over the course of a year. And speaking of change management, we had a lot of change management stuff we had to go through there. But what are we seeing now? We're seeing better outcomes. We're seeing sustained change from the ones that we have done. So I think it's around prioritizing and triaging and thinking about which ones truly do need an absolute enterprise-wide look, and then what types of things can actually be looked at in various different ways, and then how do you cascade those learnings so that perhaps at the enterprise-wide level, we don't necessarily need to see all the details of a massive event review, but if we pull themes from the various different event reviews that various different groups are doing and look at what the thematic kind of priorities are, I think that's a way to really also establish a bigger bench too for who is capable of doing this kind of learning and system change.
Thanks, Christina. Really appreciate this talk. I've been here long enough to have seen lots of different iterations of how we're going to do things. And I think one of the themes that continues, and we hear from our teams constantly, is that our ability to add complexity, because Seattle Children's is special, or we need to do it differently, is really high. We do that really, really well. So my question and my thought is, many of us have had some training in human factors, but are there groups within Seattle Children's that you know of that are bringing in actual human factors, engineers, specialists, to look at when we are designing processes, when we are building things, and if not, should we be using that more intentionally with true experts?
I don't know for sure about people, all people here at Seattle Children's, and if there's anybody on the line who is actively using that expertise for your projects and things, please let me know. We do have folks with human factors training here who are not, including you and others, who are not employed specifically in that space. There are people at the UW who are specifically available for those spaces. And there are a number of other children's hospitals who have created human factors departments. So I think this is going to be a much bigger conversation.
Hi, Ruth McDonald. This is probably a question to be answered for next time, but we have way more harm events than 7 or 8 a year. And so what do we do about the other events and be able to capture those learnings? And how are we gonna, what do you recommend for PDCAing our current process? So you don't have to answer it, but how about next time?
We teach people consistent methods for looking at harm events. We create standard processes for how we look at them, and then we pull the learning, and then we kind of have a cascade up and cascade down, right? Pull the learnings up and now analyze all together, and then think about what the fixes are from a systems perspective, and then push those back down. So I think it's really about coordinating the system together so that it's not just a small group of people like Nicole, my patient safety consultant in the back row, running these really intensive reviews that we have, but teaching others how to be able to do a version of them as well.
Thank you so much. Thank you, Dr. Tongre, for your work. Very important Grand Rounds. We'll have you back next year. Thanks, everybody, for being here, and we'll see you all next week.